Good morning, everyone. I want to thank you all for being here so early in the morning, and importantly to the organizers for inviting us to present this developing topic session to you. My name is Frank Lin. I'm a professor at Johns Hopkins, and along with Dr. Coresh, we'll be presenting to you today the results of the Aging Cognitive Health Evaluation in Elders randomized controlled trial. Most notably, the results you'll see today are being co-published at the same time today in Lancet at the same time. And the funding has come from the National Institute on Aging, which we're very grateful to for the last several years. So a first word of thanks. Dr. Coresh and I are presenting on behalf of a much larger group. The Achieve Collaborative Research Group spans about 20 different investigators and about 50 different staff across 9 different universities across the United States. This represents now sort of a body of work that began back in 2014, extending basically to the end of last year when the trial was completed. So a brief outline for today will be just Dr. Coresh and I presenting today. I'll present some brief background on hearing loss and dementia. Dr. Coresh will then go over the study design, methods, and the cohort characteristics. I'll then present evidence for around the target engagement with the hearing intervention on communication, as well as the primary outcomes looking at cognition. Dr. Coresh will then go over some of the exploratory outcomes looking at social isolation and loneliness, and finally some very brief concluding remarks before moving into a Q&A session. So the background, why we did a study and what we studied. Fundamentally, many of us have seen this figure by now from the Lancet Commission on Dementia from 2017 and 2020, including that hearing loss in mid and late life may be, in fact, one of the largest potentially modifiable risk factors for dementia. So we say potentially modifiable, mainly because of the hypothesized mechanistic pathways. So 3 major pathways have now been hypothesized to link hearing loss with an increased risk of cognitive decline and dementia. The first one being the idea of cognitive load, namely if we have degraded peripheral hearing from age-related hearing loss, there's a brain constantly receiving a much more garbled auditory signal that the brain has to reallocate central resources to dealing with that auditory decoding, and then come at the expense of our thinking memory abilities. Namely, is a tapping into the cognitive reserve that could have buffered against Alzheimer's disease pathology or microvascular disease that are typical causes of dementia in late life. A second idea sounds related, but in fact is very, very different. The idea that hearing loss in some way may also lead to auditory deprivation of the brain, leading to structural effects on the brain in terms of loss of brain structural integrity. We see this now both in animal models as well as longitudinal human studies where we see hearing loss preceding and affecting brain structural integrity, particularly of the lateral temporal lobe, but as well as other areas of the brain. And finally, the third mechanism, that hearing loss can affect social isolation and engagement, and hence affect our participation in cognitively stimulating activities or other pathways that could precipitate fast rates of cognitive decline and dementia. Now, the important thing about these mechanisms, as you can imagine, is that it's not that one is right, other ones are wrong. We're understanding on the basis of the conceptual evidence to date that likely be maybe a combination of all 3 that may mediate effects of hearing loss on increased rates of cognitive decline and dementia over time. And the reason, as you can imagine, these mechanisms are so important is because it's just something as simple as a hearing aid that's used well, that's supported by audiological support service to encourage its consistent use, that it may directly modify and affect these pathways and hence reduce the rate of cognitive decline and dementia over time. Namely, if we use a well-fit hearing aid supported by an audiologist and providing a clear signal to the brain, we certainly hope we can reduce cognitive load because a clear auditory input is sending to the brain. At the same time, we certainly hope we're providing increased auditory and neural brain stimulation. And finally, the whole reason we treat hearing loss just from a clinical perspective is to engage and hopefully promote social engagement with the people around us. So this fundamentally brings up the idea then that hearing loss may be a potentially modifiable mid to late life risk factor for cognitive decline and dementia. Now, again, the key word there is potentially. Fundamentally, this question then of whether treating hearing loss could in fact reduce cognitive decline really remained unknown. And the reason for that, as you can imagine, is from observational data, we can't causally infer from that hearing aid has an effect, mainly because people in the community who use hearing aids versus those who don't are very different. People who use hearing aids are on average healthier, wealthier, better educated, might have better health behaviors. And we can never fully control for that in observational data. A recent meta-analysis published in JAMA Neurology just from about 5 months ago conclude that hearing aid use in a meta-analysis over 126,000 people was associated with about a 19% decreased hazard of long-term cognitive decline, but with a caveat again, though, that this is a general inference. We can't prove causation yet through observational data. Importantly, no prior randomized controlled trial has ever looked at long-term effects of hearing aid use and hearing intervention on cognitive decline or even more simpler functional outcomes such as social isolation and loneliness. So the conceptual basis of the ACHIEVE trial was really simple in the end. It's basically asking, can treating hearing loss reduce cognitive decline over 3 years, within 3 years, for older adults with hearing loss and without any substantial cognitive impairment at baseline? So basically a primary prevention trial for cognitive decline and dementia. The main focus of the ACHIEVE trial is cognitive decline. There are also some exploratory outcomes. Today, we're only presenting the main cognitive results and then some of the exploratory outcomes looking at social isolation and loneliness.
Thank you. So I'll present the study design and methods as a background to getting to the main results. So the ACHIEVE study design included two populations, right? First, an existing heart health study population called ERIC, from which we recruited 238 individuals, and then new healthy community volunteers, the standard way in which clinical trials recruit participants, for a total sample size of 977 individuals. Then, as in randomized trials, people were randomized to the hearing intervention or a successful aging health education control group. And I'll call them the education control group. And you'll see the details in the subsequent slides. And then the final outcomes are 3 years later for cognitive decline. And then we have additional outcomes that we'll discuss as well in this presentation and subsequent papers. The ACHIEVE study was based within the scientific and physical infrastructure of the ERIC study. So the ERIC study is an ongoing longitudinal study of over 15,000 adults recruited ages 45 to 64 in 1987 to 1989 from a random sample of the community. So truly a random sample retained for a long time, erasing volunteer biases. ERIC's focus is on heart disease and stroke and was expanded in 2011 to include neurocognitive outcomes and hearing loss. And so ACHIEVE recruited and randomized participants at the ERIC field sites, including both ERIC participants eligible based on audiometric and cognitive assessment, so they were offered the hearing aids where everybody was screened, and a de novo group where advertisements to healthy community volunteers. The ACHIEVE cohort of 977 people was recruited from two distinct study populations, as I mentioned, the ERIC cohorts. The ERIC participants have been followed to the present day with 6 visits prior to ACHIEVE, and de novo cohort, which are new volunteers that responded to advertisements about the clinical trial focused on interventions for healthy aging. All participants were informed that they were randomized to one of the 2 interventions and offered the other intervention at the end of 3 years. To keep engagement high, people knew that they would be given the other intervention at the end of 3 years. The main inclusion criteria, therefore, are the age, 70 to 84, intact cognition as documented by the mini mental status examination, hearing loss, word recognition in a quiet room to make sure they could do the cognitive assessments well, and we'll discuss that some more, and community dwelling, with a few exclusion criteria that people were independent. So the randomization, the interventions were the 2 interventions, right? So it's a 1-to-1 randomization to the hearing intervention, which is best practices hearing intervention provision with a certified study audiologist. And we'll talk about what that resulted in terms of compliance. 4 sessions to receive hearing loss education and hearing aids and related technologies, and semi-annual visits thereafter for 3 years to receive booster sessions. The health education control was designed to have a similar level of contact. So it's an established program with 10 keys to promote understanding of key health topics, including nutrition, et cetera, important for healthy aging. And then the contact, the number of sessions, and the semi-annual follow-up afterwards were the same format, the same amount of time. So we could not blind the intervention, but we could control for a similar level of contact. The study design outcomes are basically assessed at baseline and every 6 months, in-person visits for the intervention delivery and outcome assessment for 3 years. The primary outcome is the change from baseline to year 3 in global cognition standardized factor scores derived from a comprehensive neurocognitive battery administered annually, and I'll show you the details. The secondary cognitive outcomes were domain-specific cognitive function, and I'll show you those as well. And then there are pre-specified other outcomes that we will review in detail in the next slides. So the achieved neurocognitive battery included verification of speech understanding conducted before the cognitive test. So everybody made sure they were in a quiet room and could understand the tester. Then we included these 10 tests, and only 2 of the tests had auditory stimuli alone, so a comprehensive battery. The achieved cognitive factor scores, all 10 tests are used to compute the factor score for the global cognition overall, so you get the factor score overall. There are 3 tests each for memory, executive function, and language. And then latent factors are standardized to the achieved baseline, and the change over time is in standard deviation units relative to baseline. So you start with 0 and a standard deviation of 1, and the change is from there. Incident cognitive impairment in a time to event analysis was defined by the composite of 3 things: adjudicated dementia, in-person or phone-based evaluation with 2 adjudicators, adjudicated mild cognitive impairment using the in-person evaluations, or a 3-point drop from baseline in a 30-item mini-mental status examination in person, or the equivalent evaluation from a 10-item scale conducted on the phone. For the criteria 2 and 3, in order to be confirmed, we required confirmation at a following assessment. So you needed to have the deficit and then a continued deficit at the next visit so that we knew that it was an absorbing state. In terms of recruitment, this is how we managed COVID. Enrollment started in 2018, completed before the end of 2019, started predominantly with ERIC participants, so that's the advantage of this design. You have a captive population, screened, and we get going, and then you expand to the community. Then the intervention, the follow-up visits, COVID hits in the middle, and then we're able to do the 3-year visit, again on 90% of the people, nearly all face-to-face after the main part of COVID. So that's the overall timing. The statistical analysis detail, and then I'll get you to Frank and the results, is basically the cognitive outcomes were analyzed using the estimated effect of the assignment to the hearing intervention versus the control on change in global cognition from baseline to year 3 using a mixed random effects model. We adjust for baseline hearing, recruitment source, field site, age, sex, education, ApoE alleles, covariates, and time interaction with random effects for the person, the time, and spouse pairs which were included. Multiple imputation was conducted by chained equations and used to estimate missing year 3 cognitive factor scores, which were only 10% of the people, and covariates using a pre-specified model from in-person evaluations. The main analysis used only the baseline and year 3 in-person neurocognitive scores. Year 1 or 2 in-person scores were only used when the participant died prior to year 3. And there was a pre-specified sensitivity analysis looking at a replication of the primary analysis stratified by study population, the ERIC population as I described, and the de novo volunteers. Other variations of the analytic model parameters were per protocol and causal average effect. The secondary cognitive outcomes for the secondary cognitive domains were the same analytic model as the primary outcome for cognitive impairment, and statistical significance for the primary outcome was defined as a 2-tailed p-value of less than 0.05, with the 4 secondary outcomes using the Hochberg modification for the Bonferroni adjustment. In terms of recruitment, basically we screened over 3,000 individuals. The original target recruitment was 850 individuals, and then we noticed here that recruitment was so fast that we could go past that goal, so we obtained permission, extended, and went as close to 1,000 as we could, and by October 27th, we had 977 randomized individuals. The follow-up visits are basically complete. 3-year follow-up was available on 90% of the individuals post-COVID, and the details are shown in the paper as well. So these are the baseline characteristics of all the participants. By randomization, I'm not going to show you that, but the 2 treatment arms were very similar within all the participants, and they were also similar within the ARIC cohorts randomized to the hearing intervention and the control, and the de novo into the hearing intervention and the control. On the other hand, the ARIC cohort individuals had more risk factors for cognitive decline than the de novo. Their demographics were older age by about nearly 3 years, and then differences in other demographics. Education, you can see less than high school, 9% versus 2%. Income, more people with earning less than $25,000. So you don't expect them to be similar because they're 2 sources of recruitment, but it's interesting to see their differences when you look at the study results. And they had more diabetes, more people living alone, and then the global cognition, you can see, was minus 0.379 in the ARIC cohort and plus 0.12 in the de novo cohort. So overall 0, but some differences by source of recruitment. Randomization was perfectly even within each group. So now on to the results.
So I'll present to you now some initial evidence that does the hearing intervention actually engage its target? Namely, are the hearing aids even used? And does it actually improve communication as a very proximal outcome measure to indicate whether or not the hearing intervention is even having an effect? So we look at this. These are basically histograms. On the y-axis, number of hours, going from 0 hours all the way up to 20 hours. And we see beginning at 6 months, that's the first check-in after intervention, we see a median use of about 10 hours of use. And obviously there's some spread around it, but overall 10 hours of use at 6 months. And we see over 1 year, 2 year, and 3 years that there's a consistent rate of use between 7 to 8 hours across the whole population. The median, obviously having some spread across, but clear evidence that the hearing aids are in fact being used consistently over a 3-year time window. If we then look at something called the Hearing Handicap Inventory, which is a self-reported measure of basically self-perceived communication impairment, has items like, do you feel embarrassed when you go out with friends and family? Do you struggle in conversations? It's 10 items, and it's interviewer administered. Higher scores indicate greater communication impairment. So basically 0 to 10 is usually considered no communication impairment. 10 to about 24, considering a mild, and over 24 be considered a moderate, severe communication impairment. If we first look at the control group, we see at baseline that both groups in gray, at baseline, they have very similar levels of hearing handicap or self-perceived communication impairment at baseline. In the control intervention, we see over a 3-year period that actually increases over time, which again would likely be expected because people are not getting the hearing intervention yet. So we see increases in communication impairment over 3 years. In contrast, with the hearing intervention, we see a very quick dropping down to about a level of 7 to 8, and this stays pretty much consistent over a 3-year time period. If we look then at a cutoff score, again, 10 or higher being considered indicative of a mild or greater communication impairment, again, we see at baseline between control and hearing intervention, similar rates, about 70% have a communication impairment at baseline. Then over the next 3 years, again, in the pink bar, seeing that drop dramatically with it all the way down to about 22% rate of communication impairment in the hearing intervention group, but consistently staying high and increasing actually in the control group over time. If we also looked at a much more holistic, just a self-reported like satisfaction scale, and this is after 3 years. So basically, this is only administered to the hearing intervention participants, just basically asking after 3 years, broadly, how has a hearing aid changed your enjoyment of life? So seeing very high levels of satisfaction on just self-reported enjoyment, as well as this conceptual ideas, was a hearing aid worth the trouble per se over 3 years? So this is 3 years later, seeing very consistent rates of satisfaction. All right, so you can imagine, though, does that translate across, in fact, to cognitive change, to reducing cognitive change? So this first figure I'm going to show you is a little busy. This involves the main analysis of the complete cohort, combining the ARIC cohort and the de novo cohort. What we're seeing right here, this is for global cognition. If we look at the control group, they decline by over 3 years by about 0.2 standard deviations over 3 years. If we look at the intervention group, it's basically the same, 0.200, theoretically a 0.002 difference that favors hearing intervention, but clearly no appreciable effect of hearing intervention on reducing cognitive change. If we look then within the 3 specific cognitive domains, executive function, language, and memory. Just jumping to the forest plot, again, seeing no effect of hearing intervention on reducing cognitive change versus control over a 3-year period. So disappointing at first. Now, Dr. Coresh mentioned before, one of our pre-planned sensitivity analysis was always to look specifically within the ERIC cohort and the de novo cohort separately, since these represent two completely distinct study populations. The ERIC cohort, again, was at a higher risk of cognitive decline based on the demographic risk factors. They represented more of a true random sample of the population, as opposed to the de novo cohort, which represented essentially new community volunteers responding to advertisements about a healthy aging study. When we look, first of all, at the rates of the interaction, was there statistical evidence that there might be a difference in the effect of the intervention at the ERIC versus de novo? We see for global cognition that there was indication that was interaction across different effects of the intervention across both cohorts. We see that as well for language, a P of 0.05. Again, so statistical evidence that there's differences in the intervention effect in ERIC versus de novo. And this becomes very clear, I think, when you look at the forest plot. So we look at the ERIC cohort. Again, the ERIC cohort began a higher risk of cognitive decline, representing a more of a random sample of the population than the healthy de novo controls. We see that among the individuals in the control group in the ERIC, that they declined by 0.4 standard deviations over three years, and then compared to intervention, declined by about 0.211. So we see a significant and probably large magnitude of reduction of cognitive decline, basically a 48% reduction of cognitive decline with hearing intervention for global cognition in the ERIC cohort. We see that carried across to the 3 different cognitive domains: executive function, language, and memory, all trending toward favoring the intervention. Specifically for the language domain, it meets the criteria based on a Bonferroni correction of also being statistically significant reduction in language domain, reduction in the cognitive decline in the language domain over 3 years in the ERIC intervention group. In contrast, when we look again at the de novos, we're seeing no effect of the hearing intervention in the de novo population. So a natural question emerges, well, why are we seeing such strong differences? I think a very clear indication becomes if you look carefully at the control group in both arms. So what you see if you look at the ERIC control, I mentioned before, they decline by nearly half a standard deviation over 3 years. In contrast, if you look at the control group in the de novos, they decline by 0.15 standard deviations, almost a 3-fold faster rate of cognitive decline over 3 years in the ERIC cohort than the de novo. So really following up with the fact that the ERIC cohort was likely higher risk at baseline based on the demographic risk factors, representing a true random sample as opposed to a de novo group of healthy volunteers. So one way of interpreting the data is that you can't slow something that's already going really, really slow. So if you have the de novo group with very little cognitive change over 3 years, you can't really slow down something that's even already going very slow. In contrast, in ERIC, a much steeper rate of cognitive decline over 3 years, you can actually slow something down that's actually steeply declining. If we progress then to another secondary outcome, this is looking at incident cognitive impairment. Again, as Dr. Coresh mentioned, it's based on a composite of adjudicated dementia, adjudicated MCI confirmed at 2 sequential visits, or a 3-point change from baseline to MMSE, again confirmed at 2 sequential visits. If we look at the total cohort, we're not seeing any appreciable effect. If we look in the ERIC and de novos, specifically stratified, what you first notice is that the ERIC cohort, again consistent with the cognitive decline data, have a much greater rate of cognitive impairment over 3 years. We're seeing possibly some separation of the curves at 3 years, but clearly no significant effect at 3 years, again possibly because of a relatively short period of follow-up of 3 years for looking at something like cognitive impairment. So a brief summary of the primary outcomes, of the primary cognitive outcomes. Again, the total combined cohort, combining ERIC and de novo, we see no intervention of no effect of the hearing intervention on reducing cognitive decline. If we look specifically in ERIC in a pre-planned sensitivity analysis, we see a 48% reduction, and it suggests that hearing intervention might in fact reduce cognitive decline for those at increased risk of cognitive impairment and dementia. Again, we see no effect observed in de novo, but with a caveat and a very strong but. The slow rate of cognitive change in this cohort really may limit any ability to observe, essentially for any effective hearing intervention, since it's hard to slow down something that's already going really, really slow. Just for comparison, if we look at the annual rate of cognitive change in the de novo group, it's 0.05 standard deviation, so it would take 10 years to change half a standard deviation. In contrast, seeing about 2.7, 2.8-fold faster rate of cognitive change in error controls. And if you look at the previous literature, I've looked at annual rates of cognitive change in SD units per year. This would correlate pretty closely with this being considered a slow rate of cognitive change, in contrast to error groups considered a moderate rate of cognitive change. So very consistent with the previous literature looking at rates of cognitive change in populations. And again, one conceptual idea for why there's such a much slower rate of cognitive change in the healthy de novo volunteers is, again, it represents a self-selection likely of healthy volunteers in the de novo cohort, people who responded to advertisement about a healthy aging study. In contrast, the ERIC participants came from a random sample of the population selected over 30 years ago, over which time you expect for any healthy volunteer effects to be sort of taken out of the equation. Limitations. The first is obviously the effects of the hearing intervention for populations broadly at decreased risk will need longer periods of follow-up, as well as looking for rates of, we think about incident cognitive impairment, specifically dementia, will clearly need follow-up beyond 3 years. Fortunately, this follow-up study is now in progress. Another thing to note is that possibly the control participants who did not get hearing intervention, could they theoretically do more poorly on some of the tests because they had only auditory stimuli? We will note, though, only 2 of the 10 tests had exclusively auditory stimuli. All the ones had auditory visual. We took also precautions in place to ensure that everything was done in a quiet room, and we actually verified speech understanding before testing. And we'll also note the strongest effects in the error cohort were noted specifically in the language domain, which did not have any auditory-only tests. Finally, for pragmatic purposes, you can imagine that the participants and study staff, they could not be feasibly mass intervention. It was pretty obvious if someone was wearing a hearing aid. So this was an unmasked study because of that.
Okay, so now I wanted to briefly present the other health outcomes before Dr. Lin does the conclusion. So loneliness and social isolation. What happened in a randomized setting on those items? So loneliness was assessed by a 20-item UCLA loneliness scale. The questions were about relational connectedness, social connectedness, and perceived isolation. It was interviewer administered with a 20-item scale with a score that ranged from 20 to 80, with higher scores reflecting more loneliness. Right, so 20 to 34 is no or low loneliness. This is the main result using the same format as before, and this time the overall group shows a favor to the intervention, and basically the change over the 3 years was a small increase in loneliness in the control group and no change, minus 0.02 in the intervention. So a net decrease in the loneliness of minus 0.39 and a p-value of 0.01. So statistically significant, similar in the ERIC and the de novo group, but not a very large effect, but statistically significant decrease in loneliness. In terms of social networks, we also looked at social network characteristics over the 3 years. This is the Cohen Social Network Index. We looked at measures of the number of individuals and social roles the participant has regular contact with at least once over 2 weeks, and higher scores are better on this scale. So we looked at the social network size, the total number of participants has contact with from 0 to 84, and the diversity, the number of social roles that the participant has contact with a range of 0 to 12. So 2 different results. For social network size, the hearing intervention, again, had a statistically significant positive benefit. And basically, the control group, the network size decreased by minus 0.87. In the intervention, it decreased by about half of that. So a net, lower decrease of about 0.37 contacts in terms of network size. So not large, but statistically significant, and similar in ERIC and de novo. In terms of social network diversity, again, they favored the intervention. It was statistically significant at a p-value of 0.01. The control reduced by minus 0.15 units, and the intervention basically reduced by minus 0.07 for an improvement of 0.08 and a p-value of 0.01, which was similar across the 2 groups and significant in the larger de novo group. So back to the conclusions.
So I'm going to present some just summary conclusions from the main trial results and some exploratory analyses to date. If we begin, I think what we're seeing, at least with initial data, looking at hearing aid use and satisfaction, is we're seeing an overall 3-year period, a high adherence and satisfaction with the hearing intervention. Again, the hearing intervention being comprised of the hearing aids, and very importantly, the audiological support service has supported the person in their use over a 3-year period. We're seeing consistently high results over a 3-year period, despite the effects of COVID in the interim. We then, for some of the proximal measures, we're seeing, again, positive effects on, again, the self-perceived communication impairment. That's a hearing handicap inventory, seeing a very, very quick drop within 6 months. It's sustained over a 3-year period. And subsequently, small but significant effects as well on reducing loneliness and increasing social network size and diversity. Again, this is over a 3-year sustained period of time as well. When we look at the stratified analyses, looking at ERIC, we see a significant, almost a 50% reduction in cognitive decline on global cognitive function over a 3-year period. Again, that's seen in ERIC, but not in de novo. And again, the main difference between the two groups, again, could be in the de novo group, a very, very slow 0.05 standard deviation change per year. Again, would likely limit any apparent effect of a hearing intervention within just the 3-year period. So that's the key thing, is within 3 years, not detecting effect, possibly over longer periods of time. The key inference from the study at the present time is that hearing intervention essentially may reduce cognitive change within 3 years for populations of older adults at increased risk of cognitive decline. Some implications. The findings as they stand right now, they're consistent with previous reports, both the 2020 Lancet Commission on Dementia, then most recently the 2021, the U.S. National Plan to Address Alzheimer's Disease. They both recommended addressing hearing within the context of national dementia risk reduction strategies. And I think this really brings to light that hearing loss is very, very common. There are existing interventions essentially for treating hearing loss that are widely underused. Only about 20% of people currently use hearing aids who have hearing loss. These interventions are functionally without any appreciable risk at all. And there's been evidence to date along with this trial that improves self-perceived communication and can lessen loneliness and social isolation. And also, very importantly, from the findings of this trial, suggesting that we may substantially reduce cognitive change by almost 50% within 3 years for those at increased risk for cognitive decline. In terms of broader implication within policy, one bitter irony for the United States for this, where the study was held, is that this intervention, as it's conceptualized now, would not be covered under U.S. national healthcare plans right now. And it's clearly, for countries around the world who want to think about this within the context of policy, is that insurance coverage needs to consider covering hearing intervention in this context. Importantly, from that point of view, there's 2 things to note about coverage policies. There is the hearing aids themselves, but then the audiological support service that support people in their use, which can be very, very critical, as you imagine. If you're having an 80-year-old patient who may not be very technically savvy, you have to have the support service that supports the person in the use of those hearing aids. So 2 distinct components of insurance coverage, the hearing aids as well as the audiological support services, which are likely equally, if not more important. What's next for Achieve? We alluded to this briefly, is that within the context of Achieve, the main focus was on cognitive decline. We also got brain MRIs and a half sample of the entire cohort. Dr. Coresh went over briefly some of the mental health and well-being measures. There are additional ones looking at quality of life, depression, which we have not analyzed yet. Physical functioning, we also have things looking at, we have wrist-worn actigraphy worn every year for 3 years, as well as measures of IADLs, ADLs, physical activity, and physical function as well that we'll analyze. And then within healthcare use, we have data on hospitalizations, falls, and we'll also be looking at Medicare or healthcare claims data as well over time. So determining the 3-year effects, the randomized trial effects of the hearing intervention on these other exploratory outcomes will be pursued in the next 6 months, so these papers will be trickling out over time as well. Importantly, is obviously one limitation study from the very get-go was this is only a 3-year follow-up. So what are the effects of hearing intervention for those at decreased risk? Again, we're not seeing an effect on de novo within 3 years, but it could quite just take longer as everyone may be increasingly, their cognitive decline may increase at some point, as well as looking at the risk for cognitive impairment, in particular adjudicated dementia will take longer to see. Fortunately, the 6-year follow-up study is now underway, funded generously by the National Institute on Aging. So these results will be available by 2026 or 2027 for the long-term follow-up results. Finally, we will note that we do have a poster that's tomorrow that will be describing the design of the brain health follow-up study, because it is slightly different, because there's a lag effect, potentially people who are getting delayed hearing intervention versus immediate hearing intervention. So I'll note here again the acknowledgments. There are too many people to thank, quite simply in person. This again represented a effort over 8 different universities over the last 9 years with very, very generous funding from the National Institute on Aging. This is our startup picture from over 5 years ago now, and this probably represents only about half the people involved with the ACHIEVE trial to date. We'll also note funding support. The National Institute on Aging was critical in this process. They funded both the pilot study, going back to 2014, supported a 2-year development phase, then supported the main trial, supported the MRI sub-study, is now subsequently supporting the follow-up study as well as a partnership with ERIC, funded by primarily NHLBI. So ERIC funded the ERIC cohort for the last 30 years. That serves as the basis of, again, the ACHIEVE. And finally, our colleagues at Sonova and Phonak, who provided in-kind donations to Johns Hopkins for all the hearing aids and their hearing technologies that are offered in this study. So we'll finish up there. Thank you again all very much for being here at 8 a.m. in the morning, and I think we have a good about 10 minutes for any questions that have come in from the audience. Thank you very much.
Derek Hill. Great to see such a thorough non-drug intervention study at this meeting, so thank you very much. One of the things, just looking at this, it just was so familiar in the sense that a sort of slow decline in a control group has characterized so many drug trials over the last 20 years, and you seem to have that same sort of issue. And of course, what pharmaceutical companies have done is enrich, right? Amyloid PET, or maybe tau PET are very fashionable nowadays, but actually there is something else that people have also used to enrich, which is hippocampal volume, and you've got a subgroup with MRI, and so there's an obvious question. I'm sure it wasn't pre-specified, but yep. Can it be pre-specified in the extension study that you look at hippocampal volume in the subgroup for a stratification or enrichment to see whether those people with a kind of, sort of neurodegenerative phenotype represented by the hippocampal volume might help you find a group that are going to progress more rapidly?
Yeah, excellent question. We completely agree. So within the context of our SAP, there actually is a subgroup analysis specifically looking at an AD risk profile signature based on brain MRI volume. So not specifically looking at hippocampus, we have actually an index within the ERIC cohort looking at people who are higher risk of dementia. So we can look within that, and or actually we could look at hippocampal volume too. So we actually haven't even begun the theoretical, all these subgroup analysis to be done looking at stratified by age, level of hearing loss, pre-existing risk. A very interesting within the context of ERIC specifically that we didn't mention here, but it's going to be fascinating, is we mentioned before the ERIC cohort has been followed for 30 years already, right? So the 238 people, we know their prior 30-year trajectories of cognitive function. So we can also look equally at when we begin intervention, do you have essentially an inflection point within the rate of cognitive change? So that's something we also look at as well. But we honestly haven't even begun the analysis yet, but we will though. Thank you. Natalie?
Thank you to you both for presenting these exciting results. So I have a question about the age of intervention. So the Lancet report posits hearing loss as an important potentially modifiable risk factor at midlife, which I've always thought was a bit of an epiphenomenon of the studies that they included in the meta-analysis, because those were midlife studies. So these samples are notably older than that. And you were also making the point about the intervention is more efficacious when there's a fast rate of decline. So I was just inviting your comments on when you think the interventions, in terms of how we package this to people, yep. And make this palatable. What are your thoughts on when are the optimum times for intervention here?
Thanks, Dr. Phillips. So within the context of the Lancet report, I think Dr. Cosper-Gonzalez and Dr. Livingston may be your person that can probably comment, but it's classified within the figure as a midlife risk factor, mainly because if you look at the studies they based that result on, it was actually based on 3 studies. The mean age of population, actually, the people in their 70s, 80s actually too. It's just that where hearing loss begins is likely as early as people in their 50s and 60s. So theoretically, hearing loss you can classify as a mid or late life per se. But the majority of the observational studies that they have looked at hearing loss and dementia have looked at people in their 70s to 80s. But clearly, hearing loss doesn't begin when you're 75. That's been preceded by 10 years of hearing interventions present. So it really could be broadly considered a mid to late life, mainly midlife being people in their 60s, and then late life being maybe being a 70. So it's really considered a mid to late life. Within the context of that being a modifiable risk factor, though, the ACHIEVE population was 70 to 84, right? And specifically in the ERIC cohort, that mean age is even a little bit higher, right? Because the lowest age of someone in the error cohort was 74 by virtue of how the cohort was 9 years ago. The minimum age was 74. So it's actually very, I think, from my point of view, very exciting to see that this appears to be clearly a modifiable late life risk. People, average age of 78 at this point, for arguably the people who are at the greatest risk. So I think it is very exciting in that context. The error cohort, again, was ranged between 74 to 84 at that point. So we are seeing clearly a later life intervention targeting a mid to late life risk factor having an effect in late life within 3 years.
I mean, maybe to expand for just a few seconds, I think your question about timing is very timely, and we've thought about it a lot. And I think it connects to the previous question in that for the drug interventions, we're looking at real risk trade-offs. Here we're looking at a therapy that has, no risks. And I think nicely in a randomized setting, we've shown that with the appropriate support is very widely acceptable, right? So with the appropriate support, people were extremely pleased. And then it has a range of benefits. I think what we are learning is that the hard cognitive benefits probably occur proximal to when the cognitive damage would be. I think our thinking is often that, if people have a deficit and can have multiple benefits, starting early makes a lot of sense. If you were really extremely concerned about costs and really needed to narrowly look at cognition, you could try and really get the right population. But I think for this intervention, it may become less critical. We'll do the statistical exercises, but it's a little different, as we all know, than the drugs.
Yeah, I've heard Jill Livingston say it's never too early and it's never too late. And those words have really stuck with me for a while.
Yeah, and the editorial in Lancet's actually very good as well.
Thank you, Frank and Dr. Coresh, for showing us those interesting results. I was wondering, could you, maybe you said that, did the participants who got the hearing aid wear their hearing aids in the second cognitive testing battery? Were they allowed to wear them?
Absolutely, great question. So at baseline, this is before randomization, obviously no one had hearing aids at baseline. Then once we began the cognitive tests at 6 months, 1 year, 2 year, 3 years, if you're a randomized hearing intervention, you're instructed to wear any sensory aids you normally use at home. So obviously hearing aids, reading glasses, things like that. Same thing for the control intervention. Again, bring any sensory aids they use. Again, those people had not been assigned hearing intervention. One thing we didn't show is that there was drop-in over time. So people who got randomized to the control intervention, about 16% over 3 years end up purchasing hearing aids themselves because they didn't want to wait till the very end of the study. So everyone was instructed to wear whatever sensory aids they typically use in their daily environments to neurocognitive testing.
Okay. And then another question, since you see those differences in the two cohorts. So did you look at how your ERIC subcohort for the trial compares in their baseline measures to the baseline to the full cohort of ERIC? Just like trying to understand where these differences come from the two cohorts that you're seeing?
We actually have not. That's a broader question. So we can look within the context of who was eligible for who was eligible for Achieve from the ERIC study for who joined and went. We actually have not looked at it yet, but we certainly will actually.
Okay, thank you.
Yeah, and I think, right, so these analyses are focused on the main trial and main randomization. As you say, we should do that. I can tell you that qualitatively, talking to the staff, it's quite interesting. They thought everybody liked the intervention, but they thought that the ERIC people felt like, oh, it's something you offered us, we'll take it. Whereas the healthy volunteers came wanting hearing aids, right? So that may have been the qualitative difference.
Good to say.
Good morning, Allison Lindauer from Oregon Health and Sciences. 2 questions. Did you control at all for tinnitus? And second of all, did you look at occupational risk in relation? I'm wondering if there was any differences related to economics and occupation.
We do have, actually, I don't think we have data on tinnitus at all. It wasn't something a primary focus of, so I don't think we gathered data on tinnitus. Occupational exposures, we did. We have a hearing history questionnaire looking at previous exposure to a number of rounds of ammunition they may have hired. This comes from the NHANES data, things like that. So we do have that data. We have not looked at it yet, though. Thank you, though.
Hi, Andrea Bazzoki from UNC in Chapel Hill. As a cognitive behavioral neurologist, I have been anticipating the results of this study for 3 years with much, much greater anticipation than most of the monoclonal anti-antibody interventions. So thank you so much for doing this study. How close was the ERIC cohort mean starting cognitive function to what I or you might call MCI? And how close were they at the end, the non-intervention group, to what I would call MCI, if you can translate that into like a MoCA score of some sort?
So maybe one, and thank you again for your kind words. I mean, one simple way of looking at it, it's in the main paper. It's the mean MMSE. So we actually measure the MMSE at baseline, 6 months, and every 6 months, actually, in fact. So the baseline MMSE was 28.3 in ERIC. So we're talking, this is a broadly without substantial cognitive impairment at baseline. It was slightly lower than the de novo. I think it was 28.6. I think it's very close, but slightly lower, consistent with the cognitive factor scores. You know, I don't think we've actually looked specifically at MMSE, like what the average was at the very end, but we certainly could, because I think it is something it's easier to scale to clinical use, actually, obviously.
And since the MMSE is a terrible assessment in MCI, if you could look at something like your memory scores and translate, you know, in order for me in the clinic to convince my MCI patients that it's not too late, I would love to know that. Thanks.
Thank you.
Yeah, so this cohort was more about, you know, starting earlier, but the incidence rate in the survival analyses, right, were about 8% in the non-ERIC group and 23% in the ERIC group. So a significant number, right, reached something that's like MCI.
Yeah.
Leon Fricker from Perth, Australia. Did you look at the results in the de novo group by stratifying from baseline cognitive performance and trying to find that group who you think would be more likely to have cognitive decline?
Great question. So this gets brought into the subgroup analyses, that many of which have been more or less pre-specified with the SAP. We honestly haven't done it yet. It was this was and I feel almost apologetic. This was a very compressed time frame. We locked data set essentially in April. Essentially, May was all spent on analyses. We submitted the paper to Lancet just over a month ago, so it was a very compressed time, but we've been focusing only on the main analyses. But without a doubt, to your point in previous questioners, these subgroup analyses are what we're beginning to roll out now. Just after we get this presentation done, we'll definitely start working on those. But I appreciate the thought. We definitely do need to do those.
Thank you.
I think we'll also look. I think we don't have any questions online, so I think we're actually going to finish just a couple of minutes early.
I think we're right on time.
We're right on time. All right. So thank you again for everyone's attention being here so early in the morning. And thank you again to the AIC. And, oh, sorry.
As we do have a few minutes more,
oh, okay.
I would like to ask another question.
Sure.
So Bart Volkaerts from Cochlear. I have a specific question in terms of the hearing loss, right? So the cohorts actually have a hearing loss between 30 dB and 70 dB, as I understood. Yeah? I understand actually you are still doing some sub-analysis further on. But it would be interesting to see what the effect and the effect size would be depending on the hearing loss. So let's say segment 30, between 30 and 50 dB and 50 and 70 dB. And that brings me to the question, my next question. Do we have any insights to extrapolate the outcome from the ACHIEVE study to CI candidates, those who have hearing loss above 70 dB?
Yeah, great question. So I'll phrase it, just summarize really briefly. So the range of hearing loss that people include in the study were between a pure tone hour between 30 and 70, which is, and we also a speech understanding score greater than 60%. So that's the window of people who could benefit from conventional amplification with hearing aids and audiological support services. As you go above that range, what you're alluding to is when you begin thinking that cochlear implantation might have a broader role than a conventional amplification of hearing aids. I think scientifically it's hard to directly extrapolate because we're obviously not studying that population, but I guess if I put on my clinical hat as a cochlear implant surgeon, you would certainly hope it would translate across. I think doing that study directly, I don't say it's almost impossible, but doing a randomized control trial in a cochlear implant is going to always be very, very difficult, to say the least. So I think broadly, if you look at the literature to date, we generally see that greater amounts of hearing loss associated, almost dose-dependent, with fast rates of cognitive decline. Would that translate across then to intervention effects in that population? I think scientifically we can't say that with a nail in the coffin per se, but we would certainly hope so, and we may even sort of clinically anticipate that it should, but we can't say that. Thank you. With that, I want to thank again everyone for being here, and more importantly, thank all the Chief and ERIC participants and the collaborative staff and support and funding from the National Institute on Aging for many, many years that allowed this to all be possible. Thank you.